All right. Good morning, everybody. Welcome to Grand Rounds. Before we get started with our presenters this morning, just going to remind everybody about the virtual pediatric update put on by our CME folks. That is Saturday, June 22nd from 8 until 4. It is virtual again this year, maybe for the last time. A lot of interesting presenters and topics. And so please make sure to register for that. In the chat, you will see the link to the registration. And with that, I'm going to start with our land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. So this morning we have for presenters Kelley Zwicker, who is the head of our Division of Community Pediatrics and an assistant professor in the Department of Pediatrics at the University of Ottawa. And we also have Sylvia Graham, who is the clinical manager of ambulatory care at CHEO. Dr. Kelley Zwicker obtained her undergraduate degree at Dalhousie University and her medical degree at the University of Calgary before completing residency training at the University of British Columbia. As a staff pediatrician, she then embarked on clinical fellowship in vascular anomalies at Boston Children's Hospital. Dr. Zwicker has been a pediatrician for over 10 years and is currently the chief of the Division of Community Pediatrics and an assistant professor in the Department of Pediatrics. She provides newborn care in the community at the Queensway Carleton Hospital and also maintains her skills by working at CHEO in the emergency department and providing locum coverage in various communities. Dr. Zwicker's clinical interests include general pediatric issues, as well as a special focus in vascular anomalies and vascular birthmarks. Sylvia Graham has been working in the field of health administration for over 10 years. She is currently working as a clinical manager in the ambulatory care department at CHEO and as the project lead for the Centralized Access Initiative. In previous leadership roles, including as an advisor on the quality improvement team, she has led numerous change initiatives as well as a corporate strategy implementation. Sylvia earned her Master of Health Administration from the Telfer School of Management and received the Canadian College of Health Leaders Award of Excellence. She has served on local community boards and has enjoyed volunteering at her local food bank. As a mother of 2 young children, she knows firsthand the valuable role CHEO plays in the community and is proud to contribute to the advancement of children's health and well-being. And the title of the presentation for today is Evidence for Streamlined Referral Systems in Community Hospital-Based Settings. Go ahead, guys.
Thank you. Can you hear me?
Yes, I can.
So thank you for having us. And I want to thank Sylvia as well, who jumped on board in a relatively last minute fashion to help present this project and this initiative actually that reflects a group of people coming together. And it's really important for us outside of the four walls of CHEO. So I'm excited to review some of the reasons why streamlined referrals are important. So specifically, we'll talk about what a centralized referral model is. To look at the evidence for why they're important and to explore other models within Canada and have an update about what CHEO is doing to move this centralized digital world forward. So I have no disclosures that are related to this talk, and we'll get started. So this may seem obvious, but I always like to see things in pictures. So for me, having the idea of a medical home for a patient or a family helps me visualize how the connections work together when we're trying to provide like pieces of care in the community. And so in the middle, you have the child and the family as represented by this home. And then the people that are closest probably to their care is the nurses, the allied health workers, anybody that might be involved in home-based community care. And then as you kind of move outwards to the edge of the circles, you might see other types of things that are important for healthcare, like schools and parent resources. And then up at the top, you see the specialist. And then closer to the child is the primary care provider. And so, you know, my terminology as tiered healthcare or hierarchy is maybe not the best term. However, the system is supposed to work in Canada, to my knowledge, based on the provinces I've worked in, that you're meant to have this wraparound medical home that features primary care, which we all know is a challenge right now, and then a middle level that is a little more escalated, and then the tertiary level. And so because that's a tiered approach, we need to have a referral system. And since the world of digital health has evolved over the past decade, we've seen these systems become more nuanced in terms of how they're delivered. And really, the movement towards centralized intake to streamline access to care is something that has a lot of evidence. And this streamlined approach allows a coordination of these referrals, the ability to have an electronic way or a more sort of in the moment way to check the status, a way to kind of streamline triage processes. And then if it's organized in a way that makes sort of like a structural sense, which is what Sylvia has been working on very hard in the steering committee, then there's like an administrative component, as well as like a rigor to make sure that it's providing the access to care that it's meant to do. So when I looked at the evidence for this, like ultimately, you know, I did a deep dive and went into PubMed and did a literature search looking for centralized referral systems, digital referral systems, centralized intake, or CI is another term, just kind of scouring more of the health, qualitative health literature, as well as like the informatics literature. And there's not a lot that comes out as a broad stroke look at why this is important across the board for pediatrics. There are quite a few more niche-based publications that highlight how people have done this in a very focused way. So evidence to look at specific surgical centralized referrals, or orthopedics, or mental health, or very discrete projects. Overall, there were a few papers that all my references are cited at the end, but the evidence that we could find focused on why physicians refer to specialists for advice. And the most common published reason, which seems like common sense, but it's important to think about when we're developing a system, is for advice on a diagnostic dilemma, or advice on like a management plan. That was the most common reason. The second most common was because they sort of knew what the next step was, or, you know, the management was declarative and the diagnosis was clear and confirmed, but there was no skill set or the resources that they needed to provide proper management for the patient or family was not available. And then very rarely, because most of this data is American, there's like a third party request. And sometimes I find like sometimes the families, you know, we refer because we're just not able to kind of have that assurance measure that the families would like to have. So there's definitely more evidence for these referral patterns in the adult world. There are fewer studies in pediatrics, but I think it's really important to understand what the patterns of like healthcare are within the pediatric world, because, you know, they're quite different from adults for many different ways. So if you think about this from the physician standpoint, you can understand why somebody would seek a referral, or why somebody would be providing a referral, like advice back to the referring physician. But if you think about it from the family's point of view, you know, when you're sitting there saying, okay, we're going to refer you, or like you're here because you were referred by your physician, it's kind of a critical moment, because it's reflecting like in lots of ways, like an escalation in their care, which I hadn't really thought of for a while. And then it also helps
Mona will be right there.
to lift that navigational burden, because ultimately the system is supposed to serve the patient and the family, whether that's a good old handwritten note and a fax, or whether you open your computer and you type it into an electronic digital record. Regardless of how you're referring, the relationships between those tiers of healthcare really matter. And they matter in terms of the shared management of the patient and family, because sometimes these referrals result in a one-time assessment with a management plan. Sometimes they result in ongoing care. So there's different relationships that are important. And it's really important to look at the consultation and referral patterns in our local region to help design the system in a way that makes sense for our families. So I'm going to just quickly switch and tell you about the landscape of community pediatrics right now. There's a wide variety of general community pediatricians in our region. There's a lot of different affiliations. As you probably all know, we have community hospitals that are the MA4 and QCH, and then we have CHEO, and then there's nurseries within TOH and other places. And then a lot of our community pediatricians have like specific niches that they like to practice, either in, on like only types of practice in these listed specialties, or in combination to general peds. So I won't read those all, but I will draw your attention to what it looked like in 2022. So 2 years ago, I had the privilege of presenting an update with Kathy Kelley. We had this like map that we had created from a PDF online, and we had listed all the names, and we tried to highlight who was in the division, who was not, and sort of to mesh people together. And the geography hasn't really changed much, but the move towards like a centralized digital tool has taken place, and that's found here on this network directory. And those of you probably who know me sound like that I'm a broken record, because I like to talk about this website quite a bit, but it was created as a tool for family physicians to understand where we were, and also for CHEO providing physicians and other physicians to help visualize like where all our practices are, and to understand different types of scopes of practice that we provide. What's missing on this directory actually is wait times. And we've had some preliminary discussions about how we would put these on here and how we would streamline characterizing those wait times. But there are other places in Canada who have a similar directory now, and they've decided to like post those for better shared care. The other thing I'd like you to know, and some of you may have seen this slide, is that over the past 4 years, the scope of like the delivery of care has changed to some degree in our offices across the board. So the far left bar is these are survey results over the past 4 years, starting in 2020 and moving to 2024. And you'll see in the darker blue that there was a proportion of pediatricians. The question was like, what types of patients do you see in your practice, or what kind of care do you provide? Is it primary care? And by primary care, I mean healthy children, preventative, wraparound, comprehensive care, or is it only consulting, which is the yellow? So over the past 4 years, people have moved towards providing consulting care almost primarily. There are providers that do primary care for the patients that they have. Nobody's actively taking patients, and that's evidenced by the directory, because that directory I just showed is updated every 3 months pretty consistently by the pediatricians themselves. So if somebody does have spots for primary care, you're going to see that on the directory. So I think that's an important shift in the landscape to understand as we move forward. And then the other piece of interesting information that I think might be relevant as we work through this centralized access project is looking at maybe a dated survey from 2 years ago, where we asked the community providers and some of the CHEO people as well, this is the community data, what the challenges were in terms of like communication between each other here, as well as the hospital, like CHEO as a hospital. And we had a pretty good response rate of 72 pediatricians, 39 completed the survey. It's a 54% response rate. And these categories are like analyzed thematically into 5 broad strokes. So the first one that was quite evident was like, this was in the middle of the pandemic, so there was a lot of feelings about communication, and a lot of them were positive in that, we recognized in our EMRs that we were trying our best to keep up, but we don't optimize use of what we pay for in terms of the digital tools. And then also like learning a new system that might be centralized, or like a new system in general that's digital or software based, is going to require a lot of education and time. So like feelings and perspective with regard to communication was important. Again, communication with referring physicians. So like either receiving information to us that doesn't have legible handwriting, or missing information, some of the similar themes that Sylvia is going to tell us about. And then a lot of people actually commented on a lack of direct messaging system that we could potentially use between ourselves as well as the hospital subspecialists, like the CHEO subspecialists. People highlighted safety. So how do you keep this digital information safe? What are the standards of care? Where do I learn these things? Do I go to the College of Physicians and Surgeons? Do I go to like, where's the CME to learn these safety items? And then siloed information and inefficiencies. So outside of Epic, there are many different types of EMRs, which you'll hear about in a minute, and they don't all talk to each other. And so sometimes that information is not linked together, and sometimes we don't get that information. So the labs come in a different way, or the labs might come on paper, or they come in literally 5 copies, and you have to kind of go through every copy. So the digital world has brought on more administrative paperwork, which is not a surprise. And then there's also a challenging way to understand if your referral has been accepted in some cases, and that has gotten better over time. And then again, just the theme in the survey was just ongoing review, like what does the relationship look like in our communication journey, and how can we make sure that going forward, we sustain this communicative relationship, and what does that look like in the future? So I'll just quickly go to some of the centralized referral system benefits and challenges. So this idea is that you have one electronic way to enter the request that you need to answer to help your patient and family. And this has been shown to improve outcomes, increase efficiency, if engineered in such a way where the landscape is understood, reduce administrative burden, enhance communication, and ultimately improve access, and then provide a lot of data to kind of keep on evolving. The challenges are it's hard to change. Privacy and integration are evidence-based challenges in this process. And then the one thing I really want to focus on is the disparity and the potential where access may not be equal, regardless of the type of referral system that you have, particularly in digital medicine. So there was a study that was done recently. I was out of Seattle, Washington, and they looked at the disparities in racial, ethnic, socioeconomic, and geographic challenges when accessing care. And so in this study, they did a scoping review of the literature to look for published results that describe access in terms of these populations. And there's not a lot of published literature, so an option for looking at this in our region. But they analyzed over 40,000 referrals in a 2-year period, and then examined trends in the referrals that were completed. And when they controlled for variables that were specific to socioeconomic status and demographics, it was actually shown that there was a higher proportion of families who were marginalized that didn't complete their referral. And the reasons that they proposed or qualitatively looked at for this included things like the centralized schedulers, or the system being designed to only communicate during work hours, like regular work hours, and a lot of families don't work during regular work hours, or things like needing a translator and language being really important. And so as you're going through a whole bunch of referrals to need to schedule, then you're automatically potentially going to jump to the one that's the easiest to call and review. So this was a very good qualitative study. I think there's literature like this that we have to keep in mind as we move forward, and we have to understand that there's going to be variability in the workflow for families that might be more at risk in those ways. So I'm just going to quickly talk about some Canadian examples. We'll highlight some from the West in Alberta and BC. I'm not going to talk a lot about what Sick Kids has done today, because most of you maybe already know, and I actually don't have like a full understanding. And then I know that Kingston has also moved towards a centralized referral model. So my favorite, and the one that makes me most excited, is this one from British Columbia. So it's so interesting that this Pathways platform was an initiative that was taken on by a bunch of family medicine specialists on Vancouver Island in the pandemic, because it was hard for them to access care. And they put a proposal through BC's Ministry of Health to fund this as a provincial-wide initiative. And so now, can you imagine if you don't have a family doctor in British Columbia, you can put your name into this. And I know Ontario has this, but we'll talk about that in a second. But you can put your name in here, and there's a very robust and high matching rate to connect families with family medicine specialists or other modes of primary care like nurse practitioners, et cetera. And then the other thing that's really interesting is this example from Nanaimo. So the community pediatricians have made this landing page that's been integrated with this Pathways program, where you can have a centralized referral sent to a specific pediatrician that's listed on this website. If your family already has a relationship with that pediatrician, or if you know that's the one you would like to have a consult from, your referring physician can request it. Or you can choose next available. And then there's a small team, which includes community peds as well as other health administrators, that triage the wait time. And the evidence for this has shown that they've reduced the wait times for their consultation. So you can still have that flexibility to choose the one that you may like to see, that because of there's a particular scope, like I mentioned before, or you can just try to have the fastest access. in Alberta, they've had a centralized system for a long time, and this was a directory and a way that they electronically help to match people to referrals. That I don't know much about actually, but I know that it's been there for a really long time because the way that they structure their healthcare is quite different in that province. There's many scoped referral systems listed here. So as I was saying before, when you look at the evidence for these digital referral systems, a lot of them are centered on certain chief complaints. So COPD or spine or surgery. So this repository of programs is very centralized in Alberta. Nonetheless, it helps the referring provider and the patient, because this is a public sort of domain, understand what the system is to help them seek care. And then in Ontario, locally, there are two champions that are also local to Ottawa. One is Dr. Erin Kelley and one is Dr. Claire Liddy, who have built on the e-consult system, which we're not going to focus on today, but that's part of access to care, to help the ministry understand and move the ministry forward and move sort of the priorities forward to do something that is more provincially minded in Ontario. So this has been branded Patients Before Paperwork, and there's lots of good work going on by these local physicians. One's a family physician and one is a specialist, and how we can streamline these digital referrals. So I'm going to stop talking and hand it over to Sylvia now, who's going to tell us a little more about what CHEO has done locally to help our local population with digital referrals.
Great. Thanks so much, Kelley, for inviting me to join today. And I see that we're actually joined by a couple of other members of our project team and steering committee, which is great. Thanks for coming. So I'm the lead for our centralized access initiative, and this is a project within the ambulatory care department that was really, I mean, it's been conceptualized for some time, but really made possible with the Make Kids Count investment that came because it aligns so closely with the primary goal of improving access to care. And so from an access perspective, we know from an administrative point of view that no-shows and last-minute cancellations, those are very difficult spots to fill. We know that in our department, we have a real specialized dependence on the knowledge within each of the patient service clerk teams across our 26 or so subspecialties to properly schedule, and when there's vacancies or absences that can contribute to errors. We hear from families that we put too much onus on them to be able to navigate the system, and we know over time workflows in each of our 26 different areas have evolved, in some cases become quite cumbersome, leading to greater administrative burden for our staff and medical staff. And so this project really was looking at, when we look at our referral management and we look at our scheduling processes, how can we improve access, but also keeping in mind some broader aims that we have. And so as we work to implement our improvement strategies, we're really grounding our work in this quadruple aim and balancing our approaches so that when we're thinking about patient experience or improving population health or making the most wise use of our resources and really considering the well-being of our care teams, but also our community partners, that we're not doing things at the expense of something else. Next slide, please. Thank you. So we have an incredible steering committee that really is guiding this work, and you can see from this slide here that this group is made up of both community and CHEO physicians. We have representatives from our quality improvement team. We have our team lead for our patient service clerk group. We have members of the eHealth team represented. We have 2 incredible family advisors that are part of this group, as well as our local ambulatory care leadership team. And so this group is, very reflective of a number of different perspectives of the referral management process, and attuned to many of those pain points and challenges that we know exist. And while we can't, do everything at once, we've been making steady progress on a number of different fronts. And like I said, really looking to find those balanced solutions grounded in that quadruple aim. So the area that I was going to focus on for discussion today is really around that referral management process and the work we're doing on that piece. Next slide, please. Thank you. So when we started looking at our referral management processes, we really saw there being an opportunity to better support our referring providers, both in terms of how we communicate information, like our referral criteria, our wait times, and other. At the same time, addressing some of those common challenges for our triaging providers. So we talked about the legibility of information at times, or sometimes the completeness of the information that's coming through. We've been really looking at our clerical processes and creating standard work just to improve consistency and reliability of our processes. And, we've heard from our patients and families, it can be at times a bit of a black hole when you're referred to CHEO. And so we know there's an opportunity to improve that communication with patients and families. It's also allowed us to think more specifically about what are the metrics for success when it comes to this process, and how can we have greater visibility into how things are going and monitor our performance so that we can do that continuous cycle of improvement. And this is really, like I said, there's many ways we can improve this process, and this is really laying the foundation for future improvements as well. Next slide. So there's a lot on this slide, but really what I wanted to just highlight was one of the strategies we are introducing is the centralization of referral entry. And so we've been rolling this out over the spring, and by the fall, we anticipate all of our referrals to be centralized within a newly formed centralized access team. This used to be a task that, again, was decentralized amongst our 26 different subspecialties. This is allowing us to have improved visibility into the process, reducing the amount of variability that existed clinic to clinic or clerk to clerk. And really, it's allowing us to define the best way, given the constraints that we have within our system, like what is the best way that we know how to do this work. So I'll speak in a few slides from now about our evaluation plan, but we've also been able to start an auditing process just to monitor how this is going. Another strategy is trying to reduce the amount of manual referral entry that's required in the first place. And so that's where our e-referral pathway comes in that I'll talk about now, I guess, on our next slide. So we're implementing an e-referral option for community providers through the Ocean platform. And Ocean is a platform that exists in the community. It has been integrated with a number of different EMRs in the community. So this is a snapshot here of the different EMRs that are being used within the Champlain region. And in green are the EMRs that have either full or partial integration with Ocean. Integration with Ocean isn't a requirement to leverage the Ocean platform to submit a referral, but it does create certain advantages in terms of the streamlining of the workflow when a referral was being entered. So this is a snapshot of the Ocean platform. It's a website that you can log into. You can enter some search criteria. So you could do CHEO, endocrinology, and then you would be brought to that specific services page. And you can see there's a little blue button, so you can click there to send a referral. And this is, again, something that is available to everyone, but we are aware that not everyone will be integrated. And so there will be probably different experiences in terms of adopting this particular pathway. So we did need to be able to go forward with this e-referral is actually establish a referral form. And this is where we work closely with our division chiefs and other triaging providers within our department across those 26 different specialties to really come with a standardized referral form. And as we began working on it as a steering committee, there were technical limitations that we had to consider, and so we landed here with these 5 mandatory questions that will be part of our e-referral form. So asking, is this patient followed by this concern by another provider? If yes, it would ask to elaborate on that. Asking for the reason for the referral, any relevant clinical information, medications, and the urgency of the referral, the perceived urgency of the referral. And at the top here, you'll see a direct link to the CHEO's subspecialty webpage. And I'll show you that screenshot here. So we've been working on refreshing all of our individual web pages for each specialty, and you'll see it'll be going live in a couple of weeks, but there'll be a new section and a quick link for that for healthcare providers, and that's where we'll be posting our referral criteria for each of our subspecialties. And for specialties that didn't have a web page, we have been working to create those web pages. So more information for healthcare providers. On the flip side, we've been doing the same for our children, youth, and families, updating that content as well, so they know what to expect when coming for their visit. We've also have another section of our referral form, and this is our optional section. And so these additional fields would only display if a checkbox at the top was selected to expand. And if referring providers EMR was integrated with Ocean, this is where information would automatically be pulled in from the cumulative patient profile and pre-populated into these fields, and then available to be edited by the provider. So with all of these improvement strategies, we've also been working on our reporting and our evaluation plan. So things that we are going to be reporting on includes the timeliness of the triaging process. So you can see here a bit of a snapshot of sort of overall what the process looks like, and so looking to measure how long each step of that process takes and allow us to address any challenges that we're noticing. We're monitoring our duplicate chart creation. We're auditing the completeness of the referral entry, specifically the demographic information, so updated health card, phone numbers, addresses, things like that, and making sure that information is being updated in our records. We're also adding some questions to our patient experience survey and really asking them about their experience with the referral process, as well as we're creating feedback surveys both for referring providers and our triaging providers to really assess their experience. So how easy is it to use the referral option? Does it impact how much time is being spent? Does it improve the quality of information that they're reviewing? And are there any barriers that are being faced? And so those surveys will be really important for us to monitor and be able to adjust our approach going forward. So from a communication perspective, we are planning on doing a couple of different things. Really, our key messages are that CHEO does now have an e-referral option for our medical and surgical clinics, that we will continue to accept fax referrals, but really encouraging the e-referral option where it works for folks. That our website is now updated and with referral criteria and contact information, and that we're really wanting to hear from providers about how the process is working. So we plan on all of our accepted and denied letters to include a blurb about the fact that Ocean is now a pathway that can be leveraged, and include a QR code to those surveys that I mentioned. We plan on hosting an information session for community providers, as well as using various different distribution lists to try to get the word out through emails and posters for bulletin boards. And then internally, planning on leveraging our internal distribution lists, sharing resources if needed. Our Epic team is still working to fine tune exactly how the process for a triaging provider is going to look like, but expect it to mirror what already exists. But if a tip sheet is required, we would certainly support with that, as well as an information session. So this is just a summary of the improvements that I've been talking about. The last one I'll mention is a welcome letter to patients when their referral is accepted. And this is something we're looking to introduce. So when we do accept a referral, that either through MyChart or through a letter in the mail, we let families know that the referral was accepted, what to expect while they're waiting, how to contact us, where to go for additional information and support, and trying to fill that black hole that I mentioned in terms of just the awareness over the referral and what comes next. So that's where we're at with this project, and like I said, we're excited. This is rolling out over the next couple of weeks, and so we're really excited and looking forward to hearing feedback on the work. Oh, I think you're muted, Kelley.
Thank you. We won't speak for the entire hour because we wanted to facilitate a lot of feedback and discussion and questions, concerns, critiques. I'll just sort of summarize to say that as the referring physicians on the outside, I don't want to say the outside, but outside of the CHEO institution itself, I think it's so important, and as receivers of referrals too, I think it's so important to highlight these 4 steps or these 4 tenets that can be relevant both in receiving and producing referrals. And I think that's something that as a community, we can help foster as a message, both in the peds world and also for other types of healthcare providers like nurse practitioners and family medicine specialists. So I think it's important, obviously, to prepare the patient and family properly. A really common question, once we explain why we're seeking the referral, is well, how long is that going to take? And we recognize that that's not an answer that we're able to always provide, but I do think this centralization may help be able to counsel around that a bit. I also think it's going to sort of force the issue of providing a high value question. I feel confident that the work that the steering committee has done and the input that they have have done a great job at collecting everybody's feedback. From family medicine, from community providers and families as well, will not make extra clicks, because the fields there are going to highlight what it is we need to know when we're asking for a referral. I think it's important that we define for the families what we expect of the subspecialist in terms of this is potentially just going to be a one-off with a couple of follow-ups, or we need to do shared care models, or we just need a procedure done. We think, and then to kind of take that back and explain to the families what our perspective is, and then use the education that we learned from the subspecialist to help counsel. And then this is going to provide a way to close the loop on both ends. So I think as we go forward, we're going to be able to improve the communication for our patients and families, and there's going to be a way to promote equitable access to care, keeping in mind some of that evidence that already exists. There's a paucity, but there's some there to look at the risk factors for marginalized populations. So for next steps from the community standpoint, we're going to disseminate a survey just gauging the information that community providers already know about centralized referrals, which ones they've used in the past, what their feelings are, what platforms they've used, and then talk about a way to kind of see if we can come together and define our own wait times in a streamlined way, much like CHEO does. And then provide opportunity to talk about how we're going to integrate this new CHEO-based system into our daily workflow so we can use it to its full capacity. And then in the long term, I'm excited to have this relationship ongoing from a community standpoint with the steering committee to keep evaluating how it's working for our patients and families. So I just want to highlight that I really recognize the other committee members, and I'm not the expert to be sitting here talking about this. I really like to understand why we're doing something. So it's interesting to me to sort of look at some of the evidence, but really this has been Sylvia and the steering committee and Dr. Ellen Goldblum's work as well. Or Ellen, yes. I was happy to take any questions.
Thanks very much, Kelley and Sylvia, for that super helpful presentation. Was already a question in the chat from Katie, who says, will families know if the referral is declined, or is it only the provider that gets that information?
Yeah, it's a good question. Right now it's only if accepted. We felt like there was more considerations when a referral is declined. And so at the moment, sending a letter didn't feel like necessarily the right approach for a declined referral. So at the moment, yeah, it'll strictly be for those that have been accepted. And but the letters to referring providers to let them know that the referral was accepted and declined, both of those will continue to happen.
Okay. And Mary Elena wrote a long question. Mary Elena, I know you're here. Do you want to ask your question?
Sure. So my question is whether or not when we accept a referral, we'll be able to provide any feedback to the referring physician or suggestions. So currently, we can only provide information when we decline a referral, because declined referral letters don't go automatically. There's a pause and it goes through our PSCs, but accepted referral letters get sent right away. But sometimes it'd be really nice to say, could you try these things? And if they work, cancel the referral.
Yeah. Let me get back to you, Mary Lana, because I was sort of in the impression that there might be a way to do that. And I agree, like there's accepted, but here's some interim advice to provide while we're waiting to have that initial visit. So I think it's a really important point, and I'm going to get some information and get back to you on that. I don't know if anyone here happens to know if there's a way currently.
Elena, Dr. Beck, question.
Hello? Is it
Hello.
me?
Yeah, we can hear you.
Yeah, hi. Maybe I missed the initial part, but I was wondering, I know that CHEO is very much intensively involved with Nunavut. I wonder if Nunavut is included in this. And the second part would be, how do you quality control this particular setup?
I heard the first part of the question, but sorry, there was a bit of echoing on my end, so I didn't catch the second. Do you mind repeating the second part of your question?
Nunavut involved.
Nunavut, yes. We work very closely with referral coordinators with the Nunavut population. So in terms of referrals coming in through them, it could, if they can't send them through, I know there's some providers that are connected through Epic, but if not, Ocean would be possible. But we really leverage our relationship with the OSNI coordinators to help facilitate some of that communication. But it's an important point, and it's not been an area of a lot of discussion at this point, and that is likely an area we can explore a little further as we progress with this work. And I'm sorry, I still didn't catch the second part. I don't know, Kelley, you heard it?
The second part was about how do you quality control the process? Like, what are the plans ongoing to make sure that it's reviewed and it's rigorous?
Okay, yeah. So we're working closely with our reporting team. So there are our metrics that we're tracking, and I highlighted a couple of them in one of the slides when we're looking at timeliness of the triaging process. We know there's CPO SO guidelines that we are operating within. So tracking, the various durations of time in each part of that process. We're planning on, we've started an auditing process where we randomly select a set number of referrals and really check to see, how complete is that referral entry. We're also we've created some surveys. So on the patient and family experience survey that gets sent to our outpatients following their visit, we've got questions that we are adding to really track that, as well as our triaging providers and community providers. We're creating surveys and feedback forms. And so this is the feedback that will come both to our patient care leadership team in ambulatory care to monitor and track, and that we'll also be sharing with our steering committee to help inform future directions that we take.
There's also a thanks, Sylvia. You do have an echo. I'm trying to figure out if it's because somebody else is unmuted, but I don't see that. So I don't know if there's something on your end that's giving that echo. I see a comment from Dr. Al-Bakal. Sahar, do you wanna ask that comment or have anything further related to that?
Yeah, thank you very much for the great presentation. It's really exciting, very exciting to hear about the ocean, as many MRs have an integrated ocean and will facilitate the referrals. My question was that, is there a way, for example, if the referral was triaged and deemed to be possible to be seen and referred to the community network of pediatricians, would there be a link maybe provided to the referral physician that may be referred to that link for faster access to certain services?
So we've definitely talked about that at the committee, and particularly it was a really robust discussion around like some of the ones that, like the thing that I had trouble getting my head around was whether they were triaged by the CHEO system as those lower priority. Does that mean that they warrant a subspecialist referral? And sometimes they still do, they're just not as urgent, and sometimes they don't. So I think part of that process, Sahar, is when you mentioned faster access, it behooves us as community providers to list our wait times. So, you know, there needs to be a way to ensure that that access is being granted faster. And in order to do that, you know, adding a wait time column on our directory is probably the easiest way to do that. I think it would make sense if we all use the same wait time. And this is something that we have to talk about as a group to make sure this is what we would like to see. And maybe only a small subset of us or some individuals would like to participate. But I think because it's streamlined from a community standpoint, there's a way to build on that for those that are interested.
Perfect, thank you. Sorry, I might have missed the first part of your presentation, couldn't find the link, but thank you, that's great.
And maybe I'll just comment on Dr. Zar's question as well, Hillary, if that's okay. So that website is public for everybody. You can show it to patients and families. The problem with that right now is that, you know, often the theme anecdotally, and I think we all understand, is that they want to know if they can have a pediatrician to follow their baby or their family in general. And it's a declarative way to highlight how the landscape has changed and that people are not accepting because of capacity. So there is a column there on the directory that shows whether people take consultative care, primary care, and that is a way to kind of to publicize that information. It's updated every 3 months. Everybody on that directory gets an automatic email. We were so fortunate to have a volunteer programmer who works for the Heart Institute, but he volunteered his time to build this in a way that an email token is generated. And so the token allows the provider to click on it and update it every 3 months, or do it when they know their practice is changing. So if they don't think to change it on their own because they know they're doing something different with their practice, then they're prompted after 3 months to think about, oh yeah, is my directory listing up to date or not? And if I notice that it's not up to date and I know somebody's moved or somebody's, you know, taken a leave or, you know, various different life events, then I'll chat with them or I'll highlight whether or not they want to change their status. So I hope that answers your question. And there is an electronic database. I'll just take one more step before I see Dr. Kvesi's hand. There is, what's it called? There's the Ontario website, oh gosh, it's escaping me. I was on call last night and there was a baby board who wanted to know how they get their baby's name on the website to get a family doctor. It's an Ontario-based directory and you have to put your name in there to get a family doctor. The problem is the wait time is currently 3 years because it's the provincial one is, I'm not going to criticize it on this ground rounds right now.
Yeah, Healthcare Connect, Kelley, is what's in the chat. Yes, and I think on Healthcare Connect, I think there's actually a disclaimer that says, you know, providing your information here doesn't actually even guarantee any access to a provider at all. Yeah. Dr. Kvesi has a question.
I think that's actually a great segue to my comment. I'd like to thank you both for your presentations. I think we don't spend enough time thinking about our relationship between pediatricians at CHEO and the community. And I think it's fantastic that this has been brought up. I think inside, I'll use that term. I think we're well aware of the pressures within CHEO, and we often don't think enough about the pressures in the community and the stuff that we can do that makes a difference. And obviously, these are important pieces to this, but there's more. Kelley mentioned community physicians getting 5 copies of everything that comes from CHEO. There was an OMA task force looking at that at EPIC, at TOH, and CHEO. And they decided finally that it was hopeless and not to bother trying to fix this. I think that's something which needs to be looked at again. I know it was Sahar who asked about rewriting referrals. That's something which we already have an option to do when we deny a referral. One of the things you can do is reroute it to somebody else. In most cases, most clinics then send a message to the community doctor saying, we should think you should send it to Dr. Albacal. In our clinic in respirology, I've actually tried to abolish that, and we take care of the rerouting the referral. So there's one less step for community physicians to have to do. And there's other things we can do within the institution. Our learners, when they do discharge summaries, tend to copy and paste everything, which is a lot for anyone to read in the community. Simply saying, instead of saying the X-ray and listing a paragraph, just say it's normal, which is actually a higher level form of thinking anyways, than hitting copy and paste. And the other key thing I think as us as an institution is not expecting the community to do stuff they shouldn't be doing it. So very complicated patients that really are beyond what a community physician should be managing on their own, we need to keep that in mind. Some people will discharge a patient and say, and make sure you order tests X, Y, and Z. We all have a mouse and a keyboard. We can order those tests ourselves. And the CPSO actually mandates that we do that. So I think keeping in mind the broader questions of this relationship, I think is crucial.
Thank you. I will comment that we're fortunate to have a relationship because the steering committee has been so open about taking feedback around the HRM, the health records management piece, Tom, with regard to all those duplicates. And so there's an Ontario MD chief medical officer who's local to us and who's provided some feedback on that. And that is a big mountain to climb.
Yeah, I would just echo, I think your points really resonate, Tom. And when I think about, our initial work really being around trying to stabilize certain processes and bring more stability, I think when we do that, our next step should be turning our thoughts more to some of these other areas that really make an improvement in. So thank you for sharing that.
Any other questions or comments or feedback? I think Dr. Zwicker and Sylvia would love to hear any comments, feedback about this process. Kelley and Sylvia, should any of the audience members who are here today, should they wish to provide you with any further commentary or feedback, what's the best way to do that?
For me, it'd be an email, and I could put my email in the chat, and would very much welcome anyone reaching out to me. That would be great.
Okay. And Kelley,
Same. And I'm gonna, when the recording's ready, I'm gonna send it as a link to all of our community PEDS members and the division members, which includes family medicine as well. So happy to be emailed, and also we'll share the link.
Great. And I myself had a question. I was wondering, because you had commented on it at the beginning, Kelley, about the security of systems. So, and I admittedly know nothing about Ocean. So what is, are you confident that it is secure in terms of protection of personal health information?
So that is such a good question, because it's one of those things where it's the reason everybody uses it is because it was free. Like the ministry chose this as the mechanism. And so just that in and of itself makes you think, well, it must be fine, right? But I think it's less for somebody who has no idea how to build and code and, the mechanism, how this stuff works. It's less about the program because, you know, we make our own decisions day to day when we are choosing EMRs. A hot topic that Dr. Sedana will talk about someday is AI scribe. A lot of us are using AI mechanisms. And so, you know, we look to the CNPA website and we look, some of us call and ask, we look to the college. And there is some information about how we can best protect ourselves in these early days with these technologies. In terms of Ocean, you know, in order to get in, I need to have a login, I need to have a fingerprint, and then it's also linked to your OneID. So I'm not sure if you're all aware of the Ontario like eConnect. So it's the super website for all of the house information. And you need like an Ontario ID, a OneID to access it, and all providers have the ability to do this. And it's supposed to grant you seeing like reports from other hospitals. Sometimes it's results and things like that. So that is protected in and of itself by the ministry's own build. And so we can assume that it's secure. It's sort of forced upon us. And I think it's how we use it. So you don't want to be sitting in a coffee shop with an open internet on your laptop doing patient charts, right? And you don't, you know, you want to make sure that you're using your devices and logging out, and you want to change your password so you don't use the same one for everything. So I think that kind of education, like that's about all I know about that, but that's the education piece that I think we could all use every now and then.
So it's secure to the extent that probably anything is secure in this day and age. You know, Ticketmaster, etc., etc., etc.
Your bank account, like
Everything's perfect. Yeah. Other questions or comments for Kelley and Sylvia, folks? Okay, I've got one more question just before we let you go, Kelley. So, okay, so this information, how then does it get integrated into the patient's Epic chart?
Do you want me to take that, Kelley?
Yeah, so it goes in. So good question. So so I don't know the actual techie answer, but I can speak from PSS, which if you remember that beautiful graph that Sylvia showed with all the 3 green bars and the rest of the other colors. So PSS TELUS was the most popular sort of EMR. And so when I send an Ocean referral from my PSS, it's beautiful. Like I click on a toolbar and then it opens up the portal. If I'm already logged in, I don't have to re-log in. The patient's demographic shows up, and then I can email them forms. I can do all these really fun things, and then it automatically puts a stamp in the chart. So I'm making the assumption that Epic is designed to plug into Ocean. And then when you do the thing in Ocean, you're going to get a note in Epic, like an automated recording that shows, yes, I actioned this in Ocean, or here's the referral acceptance, and it automatically populates everything you send in Ocean. It goes right into the Epic chart.
Right.
Yeah.
Sylvia, do you want to add anything? Thanks, Kelley.
Yeah, no, that's correct. It's going to operate the same way an Epic Care link referral that we currently would get into for the triaging providers and land on the triaging pool. They'll still be able to view all the information within Epic. They don't have to go to another platform, and it'll be saved on the patient chart as well.
Okay, thank you very much. We are at time. So I'd like to thank very much Dr. Zwicker and Sylvia for that presentation. There's a note in the chat also from Dr. Goldblum to say she's also happy to receive any feedback, commentary about the centralized access program. What would be great, guys, just because obviously you're in the kind of, you know, rollout and communication phase, it would be great if you could come back, you know, at a later date to show us some of the data, you know, how has it changed referral patterns, wait times, et cetera, et cetera. That would be really interesting. Remember everybody to fill out your evaluation. There is a link in the chat that Rachel provided. And again, just a plug for the virtual pediatric update, June 22nd, and you will have received emails about it. And also there's a link in the chat. Thanks very much, Kelley and Sylvia.
Thank you.
Everybody.